Thank you, Dr. Basvanagodappa. In fact, it is indeed my great pleasure to be in front of you all in a virtual world to present to you on the ECG normal variants. In fact, as Dr. BG was mentioning just about a while ago, that when we started discussing about the postgraduate education for cardiology, students of JSSMC, he suggested that we could plan one ECG, mm, kind of get together, I would say. It is not a end of the learning of ECGs. As far as we are concerned, we are ready to contribute to the course programs for many more sessions to come. And let me get on with this presentation. That is, the task in front of me is the ECG normal variants. Now, that is my present affiliations, which has been talked about by Dr. BG. Now, let's remember, friends, when we talk of electrocardiography, we cannot get away from this gentleman who got Nobel Prize for his invention in electrocardiography. He worked for nearly 50 years to kind of mature that science into clinical electrocardiography. Mind you, what we carry in our Apple Watch today was conceived over several decades, and it involved large machineries and bucket full of salines and wires connected. Paramedics also help in understanding the electrocardiography, and animal models also kind of helped. There's a blank slide just to make you kind of take a break from what I was talking to you about history of electrocardiography. And ECG works on a simple principles of string galvanometer. And of course, that I expect you to know as I'm going along. I'll be talking directly about the ECG variants. And theoretical assumptions in electrocardiography. Clinical electrocardiography is an important part of it, like, heart electrically situated in the center of the chest, and it is the volume conductor uniformly conducting the electrical impulse across the thorax and the arms and the limbs. And importantly, the limb lead or the lead systems are universally standardized, so that when we talk of ECG taken in any part of the world, it is comparable to any part of the world ECG taken at that particular moment. The analog signals that we get out of the ECG machine are actually the potential differences between the electrodes that are placed across the chest or across the limbs, not just voltages as such. ECG is recorded in a standardized manner that we all know, and many a time when we do not adhere to the rules of the game, we make mistakes. And technical dextrocardia is an important kind of technical fault one sees often in our clinical practices. Indeed, it is to be noted that ECG has to be reported in a standardized algorithmic manner to construct a clinical diagnosis in a clinical context. Indeed, without clinical context, the ECG interpretation becomes rather difficult unless it is a typical ECG. And even within the typical ECG, there could be some mistakes. As you understand more about Bayes' theorem, you will understand the pretest probability of a particular diagnosis to make in a given patient as far as the clinical scenario is concerned. In other words, we depend heavily on the clinical presentation of the patient to make sure that our ECG interpretation is meaningful to the management of the patient. As I'm talking about the electrocardiography, the electrocardiographic language is also important. Make sure that we communicate with one another across the world in a kind of acceptable language of electrocardiography. That is also important, so that we communicate as physicians across the world in a uniform manner. These are just the kind of useful reminders for us to know that when we talk of subsequent slides, these are the kind of basic foundations on which we would be learning the ECG variants. Just let me pause for a while. Some of you may not be able to see whole of this slide, but just to give you some 60 seconds time for you to spot the differences, 5 differences between these two similar looking cartoons. because I'm not able to see any one of you in a virtual platform, I will not be able to see what is the reaction. What is the reaction of uh, what is the reaction of audience? But suffice to say here that you are used to such cartoons, and you will be asked to pick up the differences, finer nuances in ECG as we go along. Now, mind you, there are 5 differences here. There is something like a change in the right socks. Pupil shadow is different. Single teeth is there in the one cartoon. There's a wristband and there's a butterfly at the bottom here. Now, do you think that you would have given importance to this butterfly? Remember that is important for you to pick up the trees when you're looking at the ECG. But also you should not miss forests in search of trees. More about it during discussion time. Now, when we talk of oh, is it so? Uh-huh. Dr. Prabhakar, can you get to Dr. Ullas connected with you?
Sure, sir.
Okay. ECG changes are common in the clinical practice. One should be aware of it, as Dr. Basangoda was pointing out, that we have to learn how to describe the ECG findings and minor variations to report them, and normal variants may be minor and they also should be documented. And of course, as we go along, we learn that there are some kind of a specific patterns that one sees in the ECG. Something like persistent juvenile T-wave pattern, a pediatric ECG with which you may be familiar, wherein V1, V2, V3 T-wave inversions may be there, and these may persist in the adulthood. These are called the juvenile T-wave inversion pattern. And ERPS, the expansion is early repolarization syndrome. Sinus arrhythmia, again a benign clinical variant, and an incomplete RBB, small r, S, and R prime. Remember, I'm sure Dr. Ullas, when he present his slides, he will be referring to this again. And of course, there's yet another abnormality that one can see in the ECG could be a wandering pacemaker. I'll try and go into these details a little elaborate manner. When we take a look at the ECG in general, if you go through these ECG changes in a systematic manner, we will be talking about the P wave, minor variations may be there, wandering pacemaker is picked up there, and PR interval, if it is shorter, then it can be kind of a possible underlying cardiac arrhythmia may be explained by this particular short PR interval, especially if it is associated with the delta wave. Of course, short PR interval, if it's too short, so-called the LGL syndrome is considered as a normal clinical variant. One should be aware of it. Now, when we come to the QRS transition may be kind of vary from person to person. And also, there will be small Q waves. Mind you, in the lead 2 and 3 and even AVF, one should be aware of that small Q wave, which may have to be ignored in the clinical interpretation. But mind you, on the basis of the context of the patient, there may be splintering of the QRS complex. People have chased this QRS complex splintering in search of the possible diagnosis of ischemic heart disease or cardiomyopathy. The outcomes may not be that very clinically important. Now, report as they are. In fact, Q-wave morphology should be described, I'm sure, when Dr. Prabhakar talks about it, what is a pathological Q-wave, you will immediately understand how it is important to ignore small, insignificant Q waves. If they are there, they may be kind of a remnant of an old myocardial infarction, or they may be part of the septal, septal repolarization that comes along. Now, of course, I am making sure that you will not miss a delta wave, because if short PR interval is reported, you should comment on a possible underlying delta wave unless you make it a point to report it. You may miss, the so-called WPW syndrome. I'm talking about J point again here. It is at the kind of tension between the end of the QRS complex and the beginning of the that should be looked into, because that could be one of the important points for us in electrocardiography to differentiate various varieties of changes. These second deviations can be described here in the form of isoelectric or depression Nagaraj will be talking about it later on. And by describing these elevations of depression, if there are specific levels at which the depression or elevation, but the clinical electrocardiography recognizes them as abnormal. A minor variation from the baseline.
Dr. Desai, there is intermittent audio failure from your side. Slight audio disturbance from your side.
Desai sir, your audio is not coming, sir.
Hello.
Now it is there, sir.
Yeah, I think it happened with BGs also. Is something to do with the electrical issue, I guess. Issue. I'm not sure. Okay, the T-wave inversions also appeared. I mean, also very important to be reported, especially asymmetrical variety. Then I'm sure when Dr. Prabhakar talks about the asymmetrical versus the symmetrical, what is their importance? Now, of course, the flattening of the T wave, very common in young women and middle-aged women. One should be worried about it. The secondary T waves, if they occur in the presence of bundle branch block, they also have to be noted as part of the bundle branch block pattern. So now go on to the specific normal variants which have been listed here. I'll be talking about these 5 varieties. You can see here, juvenile T wave pattern. I was pointing out that it is asymmetrical T waves which are inverted in the precordial leads in the adulthood, which are seen more often in women than in men, typically seen in precordial leads, which has been shown here, V1, V2, and V3. And these lead changes or these ST changes, which are asymmetrical and shallow T waves, they remain for a longer time. You can see here that example 2 also, rather showing this particular pattern, though it is a kind of an asymmetrical T wave, there is a tendency for us to jump to the conclusion. Make sure that you are not describing a kind of a juvenile T wave pattern, especially in a young woman, in case you are kind of evaluating for a possible chest pain, which may be typically not anginal. Now, look at this particular juvenile T wave pattern. You can see here 2007, the ECG showed in V1, V2 with the same pattern as one could see in 2014, indicating that these changes may persist for a long time, and these are considered as a benign and normal variant seen in women and seen in blacks also. This particular ECG was taken from a black athlete. Here you can see this ST segment changes are seen in T wave changes are seen in V1, V2, V3, and V4. And of course, there's some kind of a J point elevation also. This particular person is a black person who is an athlete. And you can see athlete ECG is also an important variant. One can see abnormal ECG in athletes. And I'm sure during discussion on arrhythmias, one can discuss, and also during ischemic heart disease, also we can see. ERPS, the early repolarization syndrome. I would like to kind of visit this particular article, which appeared just about a few years ago, as to the importance of the ERPS. Before I go into that particular article, remember the J point elevation on ECG is a diagnostic of ERPS, especially if the ST segment elevation is with concave upwards, wherein the kind of the saucer-shaped ST segment elevation is looking up. And of course, people have discussed that it has a benign arrhythmias, and in recent times, a question has been raised about the real benignity of this particular syndrome. And other detail, as I was telling about the J point elevation, and of course, the J point elevation is very typical in the precordial as well as in the kind of inferior and lateral leads also. Now, the concavity upwards is a very typical feature. And of course, at the bottom here, you can see clearly that the changes should be there at least in 2 contiguous leads. one isolated lead showing, this ST segment change along with the J point elevation does not speak of ERPS diagnosis. This particular ECG brings out this fact in lead V1, V2, V3 is not there, but you can see here V5 and V6, and also in V4, lead 2 and lead 3 and AVF are there. You can occasionally see a small Q waves in 1 and the AVL also in many patients, and see commonly the small Q waves in V5 and V6. One should not get into the trap of diagnosing ischemic heart disease just simply because you saw one small tiny Q waves. This particular arrow points out the presence of the ST segment elevation concavity upwards with the J point elevation. That's what is being demonstrated here. Not all just ST segment elevations are ERPS, mind you, nor are they ischemic heart disease of ST segment elevation. This particular ECG shows the uniform and universal elevation of ST segment elevation, and it kind of, there's a J point elevation concave upwards, and it is not distributed to any kind of a coronary tree. But mind you, this particular patient had a chest pain, and this chest pain was associated with the ST segment changes. And mind you, when you examine this PR segment, you can see clearly the PR segment is elevated, very diagnostic of acute pericarditis, indicating that all ST segment elevation should be respected, and make sure that we interpret the ECG before we call it as a normal variant. We should know the patient, we should know the complete electrocardiographic information before we file the patient. I was talking about the benign nature of ERPS, which is come under scanner, and this particular American Heart retrospective analysis of a large data talks of possible association between the early respiration syndrome with the sudden cardiac death. However, at this moment, we do not have tools to see which are these patients who have got the ERPS ECG on follow-up, and who are these patients should be followed up, how they should be followed up, what should be the counseling, and how they should be treated. I'm sure we have electrophysiologists on the panel. I'm sure he will be pointing out certain pointers towards that particular area. Sinus arrhythmia is known to us since my physiology days, about 50 years or 50 years at least now. And sinus rhythm, wherein the P and the PR and QRS are within normal relationship. And constant morphology of the P wave is important. Constant PR interval is important. And beat-to-beat variation in the PP interval. That means 3 varieties of the gradual shortening and lengthening in the cyclical fashion, like a grouping of beats as typically called, which is associated with the respiratory variation. When I show this slide, it will be very, typically known to you. You can see here the grouping of beats in the middle here, and there's slowing in the beginning, and of course, the slowing it like later on. Mind you, when such typical ECGs are seen, it can be easily recognized. But if it is crowded by a particular, all leads together, you may not easily pick it up so easily. But I would like you to study this particular ECG in the middle of this graph, rhythm strip. You can see there's a grouping here. In other words, by measuring these ECGs, intervals, PP intervals, and RR intervals and relationships, you will be able to evaluate sinus arrhythmias. You will not be making a mistake. Suffice to say, sinus arrhythmia is considered as a benign, finding, especially in younger children, and you may not see it in, older people and adults. Now, of course, small Q waves doesn't make an infarction diagnosis as a certain. Although one should know, I'm sure Prabhakar will be talking about it, losing of Q waves is more common in inferior wall MI rather than the anterior wall MI. The example 8 brings out the same fact here, that the grouping of beats, the P waves remaining the same, PR interval remaining the same. There's some kind of a cyclical variation of these grouping of the beats. I'll be talking about this incomplete RBB, the so-called the RSR pattern, small r and big S, and R prime in lead V1 and V2. Any postgraduate, when he examines and a patient is found to have an incomplete RBB with a small and a short systolic murmur in the pulmonary area, he is excited to talk of a possible atrial septal defect. But not that reason I'm trying to kind of concentrate on this particular finding, which was considered to be a benign finding, until we realized that it can be a pattern that can be seen in Brugada, arrhythmogenic right ventricular dysplasia in some patients. In other words, one should be careful about when we diagnose a so-called incomplete RBB, are we dealing with a benign incomplete RBB, or is there any kind of a or rather a kind of a, is it a harbinger of a possible, cardio electrophysiological abnormalities of the particular patient? Here you can see clearly that lead V1, small r, deep S, and a short R prime. This kind of an ECG could be considered as a normal variant, and it doesn't have a Brugada pattern, doesn't have a RV dysplasia pattern. I'm sure Dr. Ullas will be bringing to the table what are the findings of this particular pattern. This particular isolated RBB pattern is very well known to us, and we should be looking for it. Wandering pacemaker, where you can see the varying morphology of the P wave, varying PR interval also, but mind you, the heart rate should be less than just about 100. Now, the ECG here can demonstrate this particular finding. P wave, PR interval, P wave, PR interval, P wave, PR interval, all these P waves look similar. As you can see here, as you go toward the right-hand side, you can see the P wave changing, and at the end of the slide, you can see this P wave appearing as if it is was there before. In other words, some kind of a change in the ECG morphology, with the PR interval being same, the QRS rates not changing too much, and more than 2 patterns or 3 patterns of the atrial complexes talks of wandering pacemaker, a benign arrhythmia. One should be very careful if you want to rule out an ectopic atrial tachycardia. You can see this particular ECG that the wandering pacemaker is being kind of demonstrated. Now, as final thoughts, I would say with the asterisks here, measure all the waves and segments and intervals. Normal variants are important to be reported, and you may report the normal variants as a kind of presence of isolated T wave changes, presence of a small insignificant Q waves, presence of a juvenile T wave pattern, and presence of ERPS, presence of sinus arrhythmias, presence of RSR dash pattern in lead V1, and presence of a wandering pacemaker. Mind you, knowing your patient is most important in the clinical interpretation of the ECG when you are practicing medicine. Should you be interested in this particular cartoon, here you can see the doctor is being given a wrong injection into the buttocks of a patient for Botox, with a Botox, whereas he's supposed to give a flu vaccination. In other words, make sure when you take a look at the ECG, it is the ECG of the patient that you are talking of, not the mislabeled ECG, which can be a disaster for a particular patient. Now, I end this presentation by showing this particular slide to make sure that you will be intensely interested in knowing about the ECG, not by picking up particular ECG findings or benign arrhythmias or ischemic heart disease changes or cardiac arrhythmia, tachyarrhythmia ECG changes. We want to make sure that all of you get benefit out of listening to these lectures, making sure our patients are safer in all of our hands. Just died at the age of 44, and his quotes are so well known even today after nearly 65 years of his death. Thank you so much. Thanks for your patient hearing. I hope I have kept you awake throughout this presentation. Thanks so much. Thanks, Dr. Basu.
Thank you, Dr. Nagaraj Desai, for an excellent and very crisp presentation on very common ECG abnormalities that could be mistaken for a pathological one. In reality, they are normal variations.